Thank you, everybody, for joining us. We are going to be talking about metal-free implant solutions with 3D printed PEKK options and solutions. We appreciate you joining us. We know all of you have commitments from your practice to personal life, so we appreciate the time. Tonight, I'm going to serve as your moderator. I'm a orthopedic foot and ankle surgeon at the Rothman Orthopedic Institute, based out of Philadelphia. I'm also affiliated with Princeton University as a visiting research collaborator. You know, when we think about metal implants, that's been the gold standard treatment for implants throughout orthopedics for decades. There's significant pros to this, all the way from strength and durability to versatility, biocompatibility, radiographic visibility, stability, and in the past decade, the ability to 3D print and customize solutions for patients. However, there are some significant cons that occur with metal implants, ranging from implant-related complications, whether it's stress shielding, corrosion, allergic reactions, which we are increasingly identifying. You can have hardware-related issues from prominent hardware, breakage of hardware, or migration of hardware. You certainly have imaging limitations, getting scatter from MRI and even CT scans. The long-term effects of these implants can sometimes require them to be removed because of hardware irritation, or it can lead to postoperative arthritis that then needs to remove these implants to treat underlying pathologies. There's cost considerations, especially when you're talking about advanced metallurgy or 3D printing options, and weight and rigidity can be concerns as well. 3D PEKK solutions for lower extremity offer certain advantages that you cannot get with metal options. PEKK is polyether ketone-ketone implants, for which you can make bone implants that are made from this thermoplastic polymer, and it's been used and is currently continuing to be used in multiple FDA-cleared devices. Tonight, we're going to have some case presentations focused primarily on the foot and ankle and lower extremity, but it's going to show you the breadth of what we can do with foot and ankle and give you insight on what can be done across orthopedics at large. We have two exciting faculty. Dr. Thomas McDonald is an orthopedic foot and ankle surgeon at the Orthopedic Associates of Hartford and the Bone and Joint Institute of Hartford. And we also have Dr. Chris Gross, who's a professor of orthopedic surgery, the director of foot and ankle, and a fellowship director at the Medical University of South Carolina. So without further ado, Chris, do you want to take over and kick us off?
Thank you much, Dr. Parekh. You've been an inspiration in my journey of 3D printing and 3D printing allografts, so thank you. And thank you for OPM and Oxford Performance Materials for allowing me to do this today. I am really excited to talk to you about PEKK today. My name is Chris Gross, as Dr. Parekh mentioned. I'm at the Medical University of South Carolina in Charleston, and I'm going to talk to you about some of the mechanical properties of PEKK, how I took my leap of faith, and I'm going to show you a few cases of some of my successes. So it's very bizarre for an orthopedic talk to start off with a case against metal. This is how we trained. This is how we grew up. I love metal initially. The more I operated, I started seeing some issues with, the metal that I was using. For instance, a really awesome biomechanical paper from 2023 talks a lot about, the inflammatory response with metal particulate debris. So these are local cytotoxic events that may cause an individual or a patient to have metal hypersensitivity and systemic toxicity. So you can see with this ankle replacement that every single component of it is going to be releasing materials in the body. And these materials in your body are not meant to be there, and they can cause an inflammatory reaction. So all metals are corroding in your body over time. So, when we look at joints, you'll see suture tumors, you're going to have osteolysis. Global events within the body themselves are pro-inflammatory, so you can have an autoimmune reaction to this. And we know that using cobalt, chromium, and stainless steel, and even titanium can have local systemic effects. And these are far and wide ranging. So in just looking at every single type of ankle replacement that we put into the human body, you're going to see various types of metal wear. We see pitting, debris, abrasions, surface deformation, and this is not without its cost. So as the mechanical properties of the metal changes, it is going to be releasing debris into your body. So let's have a case for 3D printing. I love 3D printing. I've used bulk allografts, but I've had more success with printing large metallic and now PEKK products in order to span a large bony tissue defect. So we're using this in large defects. We can patient-specific custom size this. But the great thing is that they're not going to have graft collapse. It's stronger than bone. And there's also some coatings to promote bone growth and prevent infection. So here's a study of 3D printed spherical implants done by one of my mentors as well, Dr. Adams, in which they compare femoral head allografts and 3D spherical implants. Now, what's interesting is that the fused articulation, so the ankle and the subtalar joint, is higher in 3D printing sphere groups than the femoral head allograft group. And remember, there's not going to be any resorption. So you're going to see allograft head resorption at 57% of the time. Obviously, you're not going to see any resorption in metal patients. So there's not going to be any difference in complications as well. So what are my 3D printed options? What can I print and put into the human body? The one that we have most familiarity with is titanium. It's highly resistant to corrosion. It's very strong, especially to its weight ratio, better than cobalt chromium. Its modulus of elasticity is close to bone, which means that bone would like to grow into it. We know that a titanium oxide layer forms, which minimizes metal ion release. So that's great. And of course, we're looking for osseointegration. Tantalum, we've used tantalum, for decades. It's highly osseointegrative. It's really great for that. However, to 3D print this is very expensive. It's very time consuming as well. So you need specific machines in order to do tantalum. So maybe it's cost prohibitive at this point. Cobalt chromium, I typically use in total ankle replacements. It's ideal for load-bearing implants. However, it is very heavy and bone does not necessarily like to grow into it. Other biodegradable metals we are getting more and more experience with, like magnesium and zinc. And then here we have PEKK. All right, this is not PEKK. And, people will start to talk about it interchangeably, but it's very different, even though it's just a molecule away. So PEKK is polyether ketone. That one extra ketone group makes a difference. It allows it to be biocompatible, antimicrobial. You can osseointegrate into it. The elasticity of the modulus of elasticity is more favorable than titanium and has decreased wear debris. And you can really print this cost effectively and within a few days. So this is just a nice overall slide of what we're going to be talking about, like its superior wear properties, bone defect regeneration, antimicrobial. Okay, so here we have bone-like mechanics. This is a nice biomechanical study looking at 3D printed PEKK, which is primarily what we're going to be using in this defects, versus extruded PEKK, titanium, cobalt, chromium, and bone. And what you can see is that the tensile strength for 3D printed PEKK is close to bone. Also, the yield strength is also closer to bone. And again, all these mechanical properties are better than PEKK. All right, osseointegration. So when you're looking at a sheep bone defect model, we're comparing three different things. So we're comparing titanium coated, PEKK, and OsteoFab or 3D printed PEKK. And you can see that there is a little bit of residual bone attachment to the sample after pushing it out. PEKK has zero bone integration, okay? It just stays there. And then you have OsteoFab, or again, the 3D printed PEKK, where you have a lot of residual bone attachment. In an in vivo osseointegrative study, PEKK at 8 weeks and 12 weeks are going to show a strong evidence of bone on growth versus PEKK, which is not going to show any bone growth. Again, looking at machined PEKK versus PEEK. So again, this is not 3D printed PEKK, this is machined. The responses are significantly better in terms of fixation of the femoral rod and bone apposition. Now, when you grip blast the PEKK, it is better than the extruded PEKK, but still PEKK is better than PEEK. All right. So bone defect regeneration in a PEKK scaffold with rabbit mandibles, it can grow bone, and this osseointegrates into the rabbit mandible. In terms of the antimicrobial properties, it's going to attach a lot of things that are naturally going to inhibit bacterial and viral growth. You can see in this 2021 study that polished PEKK and unpolished PEKK has significantly decreased attachment of MRSA, MRSA, and E. coli. So it's a significantly decreased colonization of antibiotic-resistant bacteria, which is incredible when you're looking at soft tissue and bony defects that you're trying to take care of. Here we have no corrosions, no metal particles, no delamination with PEKK. It's radiolucent, so you can actually see the bone grow into it. And it's surface wicking. So here's a video over time of the fusion sphere wicking up bone marrow aspirate. And this is going to be key in attracting cells to your implant. All right. Beyond that, it is customizable on the back table. So if you have an implant and you don't like the way it fits, you can cut it down. You can drill through it. It has the feel of bone when you're screwing into it. So let's talk about some interesting saves that I've had. So here's a gentleman, a diabetic smoker, chef locally here, did not know that he had an A1C of 12.5 and very neuropathic. His angioradiographs just show a distal pilon, but given his multiple medical comorbidities, we wanted to be a little bit more aggressive. So here is a CT scan of the same individual. His plafond is smashed. So I thought I'd be clever and just fuse his ankle. Maybe in hindsight, I should have done a TTC fusion, but that is neither here nor there. I was proud of my construct. You know, I had good solid fixation. However, this is how he shows up to me at 6 weeks. He's, "Doc, I'm ready to get back to work. I've been walking on it. I've been doing great." Mind you, I keep these patients off of it for 12 weeks, and here he is at 6. And I was in a pickle. So what we did is we debrided him, put him in a frame, and I just had to get rid of that bone. I was concerned that it was infected, but also the quality of the bone was very poor. Here's some more images of what his frame looked like. And this was not a happy day for all of us. He, in fact, eventually grew out some bacteria that we had to treat him with IV antibiotics. This is what his post-op frame looks like 6 weeks later, and we started to plan, okay? And this is what our pre-PEKK CT scan looks like. Now, with OPM, we were able to plan for putting a dynamic nail in there and then 3D print a defect. And here are various images of where he is. But seeing is believing. So here he is at 4 weeks post-op. You can see bone growing along the medial aspect and, more importantly, posteriorly. 3 months, you can actually see it's almost like his bone is regrowing on top of the implant in the same shape of his distal tibia. I mean, this is insane. 4 months post-op, absolutely no pain. He's been walking on it since week 10. And just to show you that the proof is in the pudding, I'm going to put on his various CT scans to show you that the bone actually grew into the implant and around the implant. Again, he is pain-free. He is now 10 months post-op, and he is doing quite incredible. He's launched 2 businesses since we've last seen him. His A1C is below 7.5, and he no longer drinks. So here's another example. Again, same person, but just kind of a nice cartoon version of post-operative and 8 months follow-up. You see all of that bone grow, and it's quite insane. Here's another case, and I'm going to bring you through this kind of step by step on what I did. She had a pilon infected. They removed her hardware, and she has terrible arthritis and not a lot of bone left, as you can see on her preoperative x-rays. So we did take out her hardware and left her with quite a significant defect. Preoperative anatomy, this is just standard thing that you're going to be working with OPM, and Dr. McDonald is going to be talking about that later. And here's our proposed anatomy resection. So we're looking at the quality of the bone and trying to resect as much of that as possible. Again, if you can identify where you want to make your cuts, they will make a perfect match to where you want to go. We only wanted a thin layer of the talus in order to preserve talar bone stock. And this is what it's going to look like in the computer program of you putting in the implant trials and then how it affects the foot anatomy and hindfoot anatomy. So here's where we had some fun. So these were our nominal large and extra large implants. So with the extra large and large implants, I'm able to customize this as well. So let's say the nominal were too large. I can take a saw and I can shave off 3 or 4 millimeters of it. So here you actually don't have to worry about it being too large. You have to worry about being too small, which is the exact opposite of what we normally do. And you see this core right here, which is going to be the bulk of our strength, followed by a nice lattice structure, honeycombed lattice structure that bone is going to grow along, on, and into, as evidenced in those x-rays that we saw earlier. And this is what it's going to look like from the inside. They'll have some markings just so you don't put it in backwards. All right, so here we are. This is what the patient's tibia looked like after we remove the fibula. We harvest that for autograft. And here I am, doing my measurement of where we're going to make our cuts. You simply just take the implant, you stick it to where you want to go, and you cut. Here's us cutting and protecting all the neurovascular structures. And here we are taking it out. So once we take out our tibia, we're going to put in the trial. And then I'm going to start looking to see if I'm very happy with the alignment and how it fits. This is us putting in the trial and then the nail through the trial. And then here we are going to pack this bone graft with as much of biologics as you humanly can. That's an entirely different discussion altogether, but you are going to pack a lot. I'm packing all along the honeycomb structure. I am packing in the posterior capsule, and I'm specifically packing at the ends. And this is what it looks like. So this is after all the graft that we put in there. All right, and that's just the bed. Okay, so after we put the implant in, we're going to be packing it more and more so with the with biologics. And here we are putting the nail in itself. Again, for these cases, I'd like a dynamic nail. And this is her immediate post-op x-rays. Now, I'm really happy to say that I just saw her yesterday. She 3 months post-op, absolutely no pain, walking on it. We're about to get a CT scan to demonstrate healing. But here are x-rays from yesterday. And again, reconstitution of what it looks like the tibia. Bone is growing along the implant, and she is absolutely pain-free. And she has not been pain-free for a long, long time. Here's another patient that had an infected osteonecrosis of her tibia after a frame that we put on after Charcot reconstruction. I had to cut out her tibia, put an antibiotic spacer in there, and then I was actually able to recreate her tibial length and put a nail across it. Again, she is 5.5 months post-op, no pain. She's never had any pain. And this is a really key point. These patients, and again, I might be biased, but they're having less pain after surgery. I don't know why. I don't know if it's the fact that there's no metal, but they seem to be doing very, very well. And we've done, over a dozen cases at this point. So thank you again for having me tonight. It's been a pleasure to talk to you about this new technology. I'm extremely excited about this new technology. You're going to talk to a couple more individuals who are very excited about this technology. I'd like to introduce Dr. McDonald for his next presentation. Thank you.
Hey, thanks, Dr. Gross. That was a great talk. And thank you to Orthopedics This Week and Oxford Performance Materials. I'm Tom McDonald, orthopedic foot and ankle surgeon out of Hartford. And I am super thrilled to be invited to this conversation and just talk about how I came to see PEKK as a really exciting technology on the horizon to help us deal with some really challenging foot and ankle reconstructions. So my relevant disclosure is that Oxford Performance Materials invited me to the lab to do some biomaterials testing, which was super informative and educational. It's really fascinating to be on the front end of figuring out how this material is so workable on the operative field. It's a really novel characteristic of the material, and to saw it and cannulate it and drill it and see how that material responds was very educational for me. So it's kind of a philosophical question, but I think an interesting one to ask how the average practitioner incorporates novel cutting edge technology into their practice. And certainly I consider my practice to be very average. I am grateful to be associated with a residency training program and an orthopedic foot and ankle fellowship, but most of the minutes of my week are spent in a very typical private practice, an adult population, 100% foot and ankle. The only thing fancy about my practice is that I'm affiliated with this fancy level 1 trauma center in my community. And so my average week consists of pretty typical things for a foot and ankle surgeon: minimally invasive forefoot surgery, total ankle arthroplasty, sports ankle arthroscopy, community trauma, and then, randomly something like this will show up on my schedule. And so this is massive bone loss, otherwise known as a critical size defect. And you don't really need a definition. You kind of know it when you see it. But in the literature, it's defined as a bone defect in which the length of missing bone is more than 2 to 2.5 times the diameter of the bone involved. How often do we see this? Thankfully, not very often. There's some trauma registry data out there that says it happens less than 0.5% of the fractures that we see. But if you look more broadly away from trauma, just throughout the foot and ankle subspecialty, you'll realize that there's a host of pathologies that would kind of be characterized as orphan diseases. These are difficult problems that don't have a real home in our typical treatment algorithms, and that can include problems like talar avascular necrosis and bone loss from osteomyelitis or Charcot, the difficulty of converting a failed total ankle to fusion. All of these problems are full of uncertainties, and so as we look at the available and described treatment options, it's important to look at all of the ones that have been suggested and described, but it's also an exciting opportunity to look at the horizon of what's new. And so tonight we want to talk about PEKK, a 3D printed polymer allograft. And I think it's important to say that as we talk about the latest, it doesn't always mean that it's the greatest. I think all of these described treatment options have a place in the pantheon of tools that we can lean on for these difficult problems, and that would include massive structural bone allograft like femoral head, masculate technique, distraction osteogenesis, and then the 3D printed options are the ones that are exciting that we're going to get to. But as we do that and we think about, what is the best reconstructive option, again, I feel obligated to emphasize that it's always going to be, that decision is always going to be based more on patient characteristics and less on implant and technology characteristics. So what's the fracture pattern, the biology at hand, what's the physiologic healing potential, important patient cofactors, their age, their mobility status, what support structures do they have? All of these are really relevant as we choose the best reconstructive option. But as we talk about 3D printing as one of those options, the case for 3D printing rests on the fact that now through additive manufacturing techniques, we can create a highly conforming implant that is customized in any shape or size to the patient's defect or anatomy. This so-called Death Star type of spherical implant, a lattice structure, came to be 8 or 9 years ago. And that 3D printed sphere has really evolved in a rapid fashion. We talk less now about lattice structured implants and more about a porously solid implant. And the advantage of these 3D implants is that they've essentially eliminated graft collapse. That's been published. And of course, graft collapse is the well-published complication that can happen with bone allograft. With these 3D printed spheres, you can rotate the foot around and correct any number of planes of deformity. And of course, with the 3D printing technology, can create structural properties that promote bone ingrowth and on-growth. So this topic is timely. It certainly has the attention of my academy, the Academy of Orthopedic Surgeons, and this is the title article from their December issue of AAOS Now, in which they herald 3D printing as a promising alternative for the manufacture of implants. And I would certainly humbly agree with that. It also has the attention of our market, right? And so from that same article, they talk about it. A growth sector of over $1 billion over a 5-year period is fairly staggering, with North America accounting for 40% of that market growth. So all of those factors were swirling in my mind as I encountered this patient. And let's just kind of go through that case. This is a 38-year-old gentleman who was involved in a high-speed MVA versus tree. He had a type 3B distal tibial injury and an ipsilateral closed femoral shaft that was treated with a retrograde nail. He had incredibly plantar heel exit wounds from these impacted tile-driven cortical fragments. But remarkably, his lower extremity soft tissue envelope was well preserved. You've seen his AP. This is his lateral, where you can appreciate all of those distal tibial critical sized pieces driven down through his soft tissues. One of them is lodged in the metaphysis of his heel bone. And you can kind of see on the axial view how that tibial explosion kind of sheared off the lateral aspect of his calcaneus. Remarkably, his subtalar joint was well preserved, and he had about a 4-centimeter traumatic laceration at his anterior medial distal tibia, but the rest of his soft tissues were looking good. So this is what my partner did on the night that he was on call. Very reasonably, he opened up that traumatic laceration, did a thorough debridement, fished out some of those pieces, put in a bead pouch, and put on a spanning external fixature that preserved his calcaneal bone. And then he called me and said, "Tom, what do you want to do with this?" And I said, "Well, I've got some uncertainty. Like I teach my residents and my fellows, let's make a problem list, and then let's create a solution list. And these are the options that we know of for problems like this." And pretty quickly, as I went through those options, my eye was drawn towards the use of a 3D printed implant for this problem. And the reason was that, I knew it was going to be a stage reconstruction. I wanted to potentially avoid a long-term frame, like a distraction frame, with a nod towards maybe accelerating his recovery timeline. I had a young, healthy patient who was currently free from infection. He had a preserved subtalar joint, and I thought he had reasonable building blocks of vascularized bone. His medial malleolus, his fibula was reconstructible, his talus was intact. And so as I considered a 3D printed option, I wanted to kind of reflect on what my options were in terms of material. And of course, we know about titanium. It's certainly familiar. We understand its high strength to weight ratio. We know that it's 3D printable. But through some industry association and some case studies that I had encountered, I was also aware of PEKK, a bioactive polymer implant. And I wanted to learn more about that as I considered this patient's options. So what is PEKK? Well, I'm not a chemist, but I'm assured that it is one ketone derivative away from its more orthopedically familiar cousin, PEKK. And it's that ketone chain that really makes all the difference. It creates an entirely different biocompatible profile for this material. It confers a really unique antimicrobial property to the material, which is certainly compelling as we think about putting a big allograft implant into these types of scenarios. And I won't belabor that. I know it's been dealt with already, but again, like I mentioned in my first slide, the workability of this material was really appealing to me. These are complex cases with a lot of moving parts, and if your custom implant doesn't fit just right, it's nice to know that you can modify it on the field. I think it's a really compelling characteristic of this material, and it got my attention. So as I kind of stacked up those options and then saw this video, I can't tell you, I must have watched this 1,000 times. I don't think there's an orthopedic surgeon out there that can't watch this and just kind of be lulled to pleasant dreams thinking about, biocompatibility and incorporation. It might depend on what you're into, but this video is really compelling to know that this implant material can wick in and absorb local biology, hopefully to the favor of the patient's successful healing. So again, metal versus PEKK is, I consider those options, the ability to modify it in the OR, the antimicrobial properties, the ability for this material to wick in biology and osseointegrate was very compelling for me. And I wanted to know, has anyone used it before? Certainly in orthopedic extremity reconstruction, this is a new kid on the block, but it's been within the craniofacial reconstructive space for over a decade, and that was really reassuring to me. In addition, I mentioned some of those case studies I had seen. This is a case of Dr. Gross's. I just can't help but show that 8-month follow-up X-ray where you see this robust bony on-growth and integration. And that to me was much more attractive than a large metal implant with its associated stress shielding and static existence. So I like the dynamic aspect of biologic ingrowth here. I can't overemphasize when we talk about 3D printing the importance and the relevance of the preoperative planning that is kind of baked into the process of implant design. So, I know that I can sketch something out literally in my little sketchbook of horrors or on the back of a napkin, and within a week have incredible feedback from the design team and an implant in my backpack. It's really a dynamic and educational process. I want to highlight this video if I can make it play, and I won't put you through the whole 3 minutes of this video, but I tell you, to literally and figuratively be able to turn this over in your mind and see it from different angles and subtract the hardware and be able to dynamically take out your spacer and put in your implant and just really understand the working anatomy of your problem in a segmented, colorized, anatomical way was so powerful. It's a lot different than the tracing paper that we cut our teeth on. I'm dating myself there, but a really valuable part of this implant selection for me was the ability to understand it in a complete fashion. You open up your app on the phone, your OPM app, and every in between moment, in between cases, at the end of the day, and the weeks leading up to this case, is really abandoning Instagram and LinkedIn and just going to my OPM app to really understand this and play with it and manipulate it. It's super powerful. I'll just kind of get into some static pictures of that preoperative plan where, again, you can subtract the X-fix and take out the spacer and understand your zone of resection. You can understand the repositioning of the anatomy that's going to happen in your reconstructed state. You can visualize from every which angle your implant and understand its cannulation, pre-plan to fit your implant. You can pre-plan your fixation holes and understand how that's going to relate to your adjacent anatomy. You can kind of go through some mocks of antegrade nail, retrograde nail. I chose an antegrade approach for this in my effort to try to save the subtalar joint, but you could certainly go retrograde, and the ability to kind of preoperatively plan that and see how it was going to shift my hindfoot architecture was a really important part of my ultimate chosen pathway here. So you can understand how that fixation is going to fit into your distal anatomy. And then, once you've done all of that planning, the rest is really just plug and play. So this is his first staged approach where we took out his bead pack and took out, you can see all of that remaining tibial bone that we extracted, devitalized segments, just did a really robust, clean and debridement of the tissue envelope, and it was really healthy looking. We took cultures, put on a more robust circular frame, fixated his fibula, kind of brought that out to length, put in an antibiotic impregnated spacer to replace his distal tibia, and got a CAT scan afterwards. And again, I was pleased with what I had to work with. I had a good subtalar joint, had good blocks of bone, and I could kind of understand that with some more preoperative planning. And then, 6 weeks later, just kind of leaning on tried and true Masquelet principles, carefully preserving this richly vascularized biologic induced membrane that forms around your cement spacer, full of osteogenic potential. And then here's our PEKK soldiers lined up. They're ready to go. We've got our nominal size and one a little smaller, one a little bigger, just to have that option in case the soft tissue warranted it. And it's ream and dream. We just kind of instrument from an antegrade approach, collect those reamings. We apply the biologic schmear, if you will, just kind of, again, knowing that wickability characteristic of PEKK is going to work in my favor with whatever biologics I choose to add. We just pop our pre-printed tibia in. It fits right into that membrane, fits like a glove against the anatomy that we've planned, and dock your fixation distally. And here you can see on that slide on the right that I'm able to localize the pre-planned hole in the PEKK implant. I know that's where I want to put my cannulated screw and bring the medial malleolus back to that. And then if I decide I wanted to do something extra like this crossing fixation screw, no problem. It was super powerful and again reassuring to know that if something wasn't going as planned, I can instrument this and put in additional fixation. You just can't do that with metal. So that's really exciting to me as I think about future potential reconstructions. So here's my patient at 4 months, and he's not infected, and he's appropriately swollen. He's got about a 6-hour community walking endurance currently. He is able to single leg stand without pain. He's in a boot. He's sheepishly admitting that around the house he's walking in slippers. I'm trying to cajole him into getting into a polypropylene AFO. That would make me feel better because his x-rays, to be honest, are not what orthopedic surgeons are used to looking at here. And so this is a little bit of a leap of faith, to be quite frank. I'm recalling Dr. Gross's 8-month x-ray, and I'm magnifying my 4-month x-ray and looking for calcific spiculation. We got a CAT scan because I needed a little more, and that's reassuring to see this smooth integrated interface at the distal end of the implant. You can see that calcium on growth happening, kind of creeping up the posterior aspect of the implant. Proximally, you can see that induced membrane biologic wrapper going to work for us and starting to wrap and calcify the proximal end of the implant. But as a wise man once said, we'll see. And so I like this quote. I came across it at our winter meeting at AOFAS, and I had to steal it from one of my mentors who quoted Kissinger when he said, "To be absolutely certain about something, one must know everything or nothing about it." And I really identify with that quote very profoundly. And so I can't bring certainty to this conversation tonight, but hopefully I've been able to show how I became interested in PEKK and maybe to answer the question, how do we integrate new technology into a typical practice? And I think, as always, it's often going to be unusual cases or exceptional patients that kind of force us to critically examine this crossroads where really difficult problems meet innovative solutions. And I'd say that it's important for us all to develop our own guardrails for the safe and ethical implementation of this technology. And for me, the priority is always going to be shared decision-making with our patients. I think that's super important to emphasize as we bring our patients to new and innovative solutions. So thank you once again. Thank you all for your time. I'd say thank you very much and have a happy, creative, balanced 2025. Stay curious. I'll turn it over to Dr. Parekh, and thanks once again.
Thank you, Dr. McDonald. I'm now going to share with you my perspectives on the early integration of PEKK into my practice. One of the issues that we know exists with metal implants is the creation of a biofilm. And we know that once bacteria latches onto the metal, it can flourish through a glycocalyx and through a biofilm that then gets created. And this can be challenging for the surgeon as well as the patient for outcomes. We also know metal hypersensitivity is a real thing. And in fact, in the last 5 to 10 years, we're increasingly realizing how much of an issue this is. The type 1 hypersensitivity is rare. This is the dermal hypersensitivity you get, but the delayed type of hypersensitivity, known as type 4 hypersensitivity, is more common. And most recently in Nature, there's been a study looking at metal allergies and hypersensitivity in total knee arthroplasty. And we've published on this in 2023 for our experience in foot and ankle, which has increased over time. Contact dermatitis can be due to the metals that are normally found in these inert implants, whether it's nickel or cobalt or chromium. I've seen it all the way, including titanium and salts that generate off of these implants as well. Now, this kind of contact dermatitis can be found in 10 to 15% of the general population. Of all the metals that occur, of all the hypersensitivities that occur in these metals, what we see most often is nickel, and that can be in 10 to 20% of women who are wearing different types of jewelry on their whether it's their watches, whether it's their jewelry on their rings or their earrings. And we see this nickel hypersensitivity, and we will screen these patients verbally at the onset of our evaluations with these patients. Now, metal hypersensitivity clinically is not very pervasive. It is uncommon, affecting 1 to 5% of patients. Asymptomatic metal hypersensitivity, where you have a positive skin or blood test without clinical symptoms, can be found in patients who have, in 10 to 25% of patients who have orthopedic implants. Patients with failed implants or unexplained pain can have hypersensitivity at a much higher rate, anywhere from 10 to 30% of the time. So in the back of your mind, you constantly have to be thinking about patients who have unexplained pain or swelling or difficulty with their outcomes outside of what you expect. Is there an underlying metal hypersensitivity that the patient is unaware of? And it's not infrequent that the patients are not aware of their hypersensitivity, and it's only after their surgeries and the recovery that this gets uncovered and becomes a problem for them. Now, common metals that we see this hypersensitivity, again, nickel by far leads the metal allergies or hypersensitivity, but I've seen it in cobalt and chromium and titanium. And most recently, I heard a patient who said she had it with molybdenum as well. So I think as the field continues to be sensitive to these hypersensitive issues, we will diagnose more and more of the possibilities of hypersensitivity to metals. Now, when you see these patients, oftentimes they can be confused with an inflammatory process going on in the area of concern for us in joint replacement areas. They can also look more like an infected picture. These patients can have persistent pain, swelling, erythema in and around the area of the surgery. If they've had a joint replacement, they can have aseptic loosening or failure. And then they can sometimes have even dermatitis in small little patches around the joint that has been replaced. Systemically, these patients can feel pain. They'll talk about swelling, stiffness, which are common things that you sometimes see after surgery, but they may even have systemic symptoms of fatigue or joint pain or having widespread inflammatory symptoms. And you have to be open to the possibility of hypersensitivity being a real issue for these patients. There are different ways to test hypersensitivity. You can do a patch testing, and this is for patients who have suspected metal allergies, but it's limited because it's not great at looking at hypersensitivity of internal implants, right? The implants that we are putting into these patients, this is not a great way to test it. This is really more for dermal hypersensitivity, which I think is different than implanted hypersensitivity. You can do the lymphocyte transformation test, and this is looking at the hypersensitivity as measured by the lymphocytes reacting to the metals. There is a company that does this based out of Chicago, and you get a lab result that looks similar to the report you see here on the right, and you'll see the bar of the positive control and then where the patient may or may not be pinging for a variety of different orthopedic metals that are used throughout our surgeries. And then you can always get a histological analysis. Now, this is done patients who have second look surgeries or are having a revision, where you can take some of that synovial lining, send it to the pathologist, and they can look for the lymphocyte infiltration into the area, looking for inflammatory processes going on. So those are the three ways that you can diagnose this. Now, what are some of these issues that we see with metal that we think can be solved with PEKK? Well, we see stress shielding. We know stress shielding occurs when there's a mismatch between an area where bone has the metal, so it's increasingly rigid, to an area where there's no metal. And so at that interface, you can see stress shielding. And this is a case of a TTC fusion that was done. And at the tip of the nail, you see that mismatch lead to a stress reaction, which then ended up into a true fracture in this patient. And in this case, the fracture progressed all the way to the most proximal screw hole, and now that screw is backing out. So stress shielding is something that we can see in the right setting for foot and ankle surgery. Implant scatter is something we see across imaging throughout orthopedics. And in this case, there's a patient who had an ORF, the medial malleolus, required a MRI to evaluate the deltoid. And with that MRI, you can see the scatter that occurs, and it makes it more difficult to interpret these images that are then you are then relying on to make treatment protocols for. And so to have an implant option that avoids the scatter is very beneficial to patients, whether it has to do with their primary issue or subsequent issues that occurred down the line. One of the things that we have seen challenges on in the 3D printing world is metal implants have to really precisely be manufactured so that either you have options, multiple options, to work with different implants that are of different sizes, different shapes, to address the patient's pathology. But if none of them work and you have to modify these implants, you struggle because you can't easily modify these metal implants. And there have been times where I've had to take a diamond burr and cut the implants, but it leads to metal shards being passed throughout the surgical field, and you're trying to make sure that those metal shards don't make it into the body, and it's challenging. So having an implant like PEKK, where you can modify it in the operating room, is a huge advantage for us when we deal with these difficult pathologies where you sometimes have to make audible calls in the operating room. So I'm going to share with you some cases early in my adoption of PEKK and share with you the breadth of cases that we can do. Here's a patient who had a in-bone with a total talus, historically has had an ORF at the calcaneus, presented to us about a year out from the surgery, and is having chronic pain and swelling, had seen multiple providers from the state he was at, and they had all recommended an amputation. The patient wasn't interested in amputation, but was looking for a way to salvage their limb. And as an aside, the patient also had about an 8-centimeter limb length discrepancy. So stage one was to go in and clear the infection. And we put the patient in an external fixator, lengthened over the external fixator so that we could regain some of the length that had been lost, put the antibiotic cement spacer, supplemented this with IV antibiotics, and waited till the IV antibiotic course had been completed, gave him about a 4 to 6 weeks holiday to ensure that the infection did not come back, and then brought him to the operating room. Now, in the meantime, we had designed this kind of spherical nose type of implant where you have the PEKK cage that allows for ingrowth throughout, has a hole in it so that you can pass a TTC nail. And we approached this patient with multiple sizes, so we had options if we needed, but we also knew that we could modify these implants if we needed to, cutting them, shortening them, shaving them as we needed. So we took a lateral approach, took the acetabular reamer and prepared the recipient site. We sized it with our different trials, which we had made as well. Those are also made out of PEKK. And once we selected the right size, which you see in the upper right-hand side, we then placed the implant in, packed it with graft, and then passed our nail. Now, interestingly, when we passed our nail, we had already pre-planned where I wanted it, the implant navicular screw to go. But once we passed the nail and fixed the nail and the implant was in, the PEKK implant was in, I realized that where I had planned to put that screw wasn't ideally where I wanted it in the operating room. So here we called an audible. We were able to drill through the PEKK implant and put this screw where I wanted, and then place the screw for the tailor-navicular fusion. And so here you see here, this patient is at this point about 5 months out from the surgery. You see the robust bone growth that has occurred around the implant, but through the implant as well. He's stable. He had a tailor-navicular fusion as well as the ankle and subtalar fusion. There's been no signs of recurrence of infection, and he's done well and has salvaged his limb to date. Here's a patient that was sent to me, has avascular necrosis of the talus. You can see it on the MRI views, and it goes full thickness. Now, this patient had told me that she had metal allergies that she was aware of. She thought only to nickel because she was having it with cheap jewelry. So we went ahead and got her tested. Now, when we got her tested, to our surprise, not only was she allergic to nickel, but cobalt, chromium, and titanium, which knocked out any possibility for any type of metal implant. And so this was just about the time that we were starting to do PEKK implants. We thought this was an opportunity to really do a PEKK implant. So here we are opening up the ankle and anterior approach like you would do for a total ankle. You go down to the talar neck and body. I do a osteotomy through the neck. We remove that neck, and that separates the head from the body. And then in this right-hand picture here, you're seeing that I'm taking quadrants out of the talar body, and then I'll remove that. Once we're done, you can see that we are looking at the talus itself, at the open space from the talus being removed, from the talectomy being performed. We have trials that we can use, and then we can implant our final implant. Now, what I'm showing here on the left side is a sample that does not get implanted, but essentially this was the size that we use on this implant, on this patient. And on the right-hand side, you can see the open area of the talar PEKK implant. So she has a total talus replacement. For 7 years prior to this procedure, she had been non-weight bearing. She worked at one of the airlines, big airline companies, flying on the planes, and she had not been working for 7 years. She finally got an implant that she could use, is back to gainful employment, and this has changed her quality of life. And so far, she's doing well. This is a patient of ours who comes in, has ankle arthritis. He also happens to work for one of the big airline companies. Has ankle arthritis, post-traumatic, gets a standard total ankle replacement. In this case, we're using one of the systems that I tend to prefer, but this could be any system on the market. He does well for about 3 to 4 months. And after that period of time, he starts having pain and swelling. We do $1 million workup to make sure he's not infected. We get a SPECT CT scan, and we see this inflammatory process going around his ankle. I ask him at that point, is he aware of, I should say, I re-ask him, is he aware of any metal allergies that he's ever had? He does not know of any metal allergies that he has. So then we get him metal tested. Turns out that he's allergic to aluminum. So once again, we look for options that can be aluminum free. This is the first isolated total ankle, PEKK total ankle that was done. And we designed it appropriately. This is a mobile bearing option that allows us to then put a mobile bearing poly, which is what you're seeing, the metal line, the metallic line through the middle of the joint. He is now about 5 months out from the surgery, doing very well. In fact, he was just quoted saying that he has 300% improvement in his quality of life since having this done compared to the metal implant. So recognizing the source of his pain and addressing it with a solution that can remove metal out of his implant, remove metal out of his outcome, was very important for him to get the outcome he wanted. Here's a patient that saw me, had prior surgery done with metal hardware for a TTC fusion. And she's drifted in varus over time, and now is walking on the lateral edge of her foot. And it's gotten to the point where it's very painful. She tells me that she actually does have a metal allergy. She doesn't know what the metal was, but her hardware that got put into this original procedure all had to be taken out due to a metal allergy. We don't have records of the surgery implants that were used, and for a variety of different reasons, she was not able to get metal tested. She was absolutely adamant that she did not want me to put any metal in her whatsoever, even something that maybe we would remove later on. So this was, again, another patient that it was very appropriate to get for her a PEKK wedge, where we could do a supramalleolar osteotomy, correct the foot deformity, that varus deformity at the hind foot and at the forefoot with the supramalleolar osteotomy. We could span it with an external fixator to help hold this in position while she heals. And she's still in the frame, and we're waiting for consolidation to occur so that I can take the frame off. But so far, she's been happy with having no metal permanently residing in her. So PEKK has really great material properties that we are taking advantage of through these cases that we're showing, and that both Dr. McDonald and Dr. Gross have shown you. It's biocompatible, it's hypoallergenic. I've shown you some cases where the metal allergies were real and were affecting patients' outcome, and PEKK was able to prevent those in some patients or correct them in other patients. It has bone-like mechanical properties, which we take advantage of with our cages. Whether you're doing big cages spanning multiple centimeters, or you're doing, a smaller cage or a cotton or Evans type wedge. It's corrosion-free. It allows for osseous integration. We're seeing it on our cages, not only on the external part of the cages, but actually occurring through the cage itself. It's clearly radiolucent. I've shown you some x-rays where you see the radiolucency, so you can actually see the bone growth occurring, which is really nice. It doesn't allow for scatter to be a problem for patients who need advanced imaging after these implants are placed. It has inherent antibacterial properties, minimizing the glycocalyx that can form, the bacteria that can latch onto these implants, which is huge in many of these cases that we're doing for limb salvage, because often many of them are infected cases that we're trying to deal with. It's modifiable in the operating room. And I showed you the case where I had to call an audible, but it worked out perfectly because we had a PEKK implant. It allows for freedom of design of complex implants, and cost and turnaround advantages so that you can get these patients into the operating room quicker, sooner, faster. Now, it has a distinct weight difference comparing it to titanium or cobalt chromium. So what has happened for my practice is anybody who requires an isolated total talus replacement, we have started moving them towards a PEKK implant because of the decreased density of the implant. And with that decreased density, I'm hoping that we are seeing less wear on cartilage all around that total talus implant. You have to be able to polish these implants. And because you can polish it, we are hoping that, again, we're seeing better wear against cartilage. Time will tell how this does. We are still looking back at our metal implants and looking at what is the rate of progression of arthritis and the need for more surgery after an isolated total talus. And over time, comparing the outcome of the PEKK versus the metal will become important for us. Again, we do believe that this will wear better against cartilage that is remaining and give us better outcomes long-term for patients. So with that, we will open the floor to questions. All right, so we're getting questions coming in. Chris, why don't you take this one? How were you able to take the leap of faith to move to PEKK from metal?
Dr. Parekh, that's a very good question. It was a challenge. I have, worked with you designing 3D implants for quite some time. I love my 3D metal implants, but there was something missing. Like maybe I'm not doing it good enough, or I'm starting to see some non-unions, or I don't know. I needed a change. But what really led me to take that leap was just a patient whose leg I was, purely limb salvage. That first patient that I showed you really was my leap of faith. I did not expect a diabetic smoker, just poor social status, to heal that. I did not at all. I wanted to try something that I deemed unsalvageable. He wanted me to save his leg. I promised him that I would give it my all and my best. However, I wanted to see the power of this technology. And this was my first case. And I really just wanted a good test use. Once I saw his 6 weeks x-rays, I was a little bit of a believer. Once I saw his 3 months x-rays, I was just blown away. I mean, I've never seen bone on growth onto an implant ever in any metallic additive technology that I've done. And it just truly won me over. And then once we got the CT scan and I'm just watching bone bridge such an enormously large defect, I couldn't stop. So, you know, every single patient that may need something like this, I am now looking towards PEKK as kind of the standard in the future.
I got another question here coming in. Dr. McDonald, what advice would you give to a surgeon who is contemplating using PEKK for the first time?
I think that's a great question, having recently been in that position. Happy to field that. You know, I tried to intimate in my talk, there's a growing resource of case studies out there and a growing community of early adopters that I think is really important to lean on in this new horizon, new space of technology. You know, the surgeons that I talk to, kind of the KOLs under OPM's umbrella, were super helpful for me, very open and just sharing their case experiences, maybe their implant design ideas. And I think it's a tremendous resource that really pairs nicely with that 3D software and segmented anatomy understanding. It's just a great resource that I think is baked into OPM and OsteoFab cases, and I would encourage people to utilize it. It was very helpful for me.
Chris, I got another one for you. How have your patients in the short term benefited from metaless 3D implants?
Yeah, that's a good point. So what are the benefits for the patients? And we went through a whole, you know, slide deck, but really postoperatively is what I'm really concerned about. Number one, I've had nothing but limb salvage. Again, it's a short cohort, small follow-up, you know, less, you know, about a year for some patients, less than a year for others, but we have over a dozen now, and we're able to save their limbs. Not only that, it seems to be, again, this is anecdotal, they're complaining of less pain. Our PROs, once we aggregate them, will tell that story and prove that, you know, once we have the data, we'll prove what I'm talking about. But just anecdotally, people are having less inflammation, less pain after the surgery, and it's making recovery a lot easier for them. You know, maybe it's less of an inflammatory response with the soft tissues, and we're doing like really big surgery. So, you know, I expect them to be in a lot of pain despite them being neuropathic, but they're just responding better to the implant. They're not, you know, having the non-unions that I used to see with the titanium implants. I've just been really happy with it.
What are the key material properties of PEKK that make it suitable for orthopedic implants? Guys, I'll take this one too. For me, it really boils down to a few things. Most of these cases that we are addressing are limb salvage cases. And in that situation, I'm either looking for a bone replacement, like a talus replacement, or I'm looking for a cage that allows for bony growth, but restoration of anatomy and length. And so what I'm really looking for are implants that can give me the ability to decrease any kind of microbial activity on the implant. So having that antimicrobial presence in the patient whose milieu may have already been exposed to infection, I think is very important. So the antibacterial properties is very important to me. Secondly, the osseous integration is critical, right? You can put any implant you want in, but if there's no integration into the bone, then that implant will fail over time. So having a property where the bones, the osteocytes really love that implant and can grow across it, I think is critical and really sets you up to success for these complex fusion cases. And then finally, for me, it's the hypoallergenic nature of PEKK. We are, like I said, increasingly seeing more and more of these allergy issues, hypersensitivity issues being recognized. And with that, I think it behooves us to try to provide solutions to patients who need it with hypoallergenic implants. And this is where the PEKK implant really sits in nicely. So for me, those are the three properties that make it compelling to use PEKK in these difficult situations. All right, everybody. Wow, I want to respect everybody's time, and it looks like we are hitting up on our time. I'm sorry if we were not able to get to all of the questions, but the OPM team will absolutely follow up with anybody who has outstanding questions, either now or if you have questions later on, feel free to reach out to the team. Again, thank you for joining us, and feel free to reach out to any of us if you have any questions as well. Thanks.